Hello everyone. So today is our fifth lecture, Emergencies in Pediatric Oncology. So we have four speakers and moderation will be done by Dr. Juhi. So to introduce, Dr. Juhi Shah is a consultant in Pediatric Hematology in Fortis Hospital, Mumbai. She'll be moderating the session. Then we have speakers who will be talking about various emergencies seen in medical. Like we have divided it in three sections. Medical aspects will be taken by Dr. Vasudev Bhat, who is associate professor in pediatric hematology and oncology in Kasturba Medical College, Manipal. Surgical aspects will be covered by Dr. Shalini Mishra. She's a senior consultant in pediatric surgical oncology and works in Rajiv Gandhi Hospital, Delhi. Interventions in emergency would be taken up by Dr. Nitin Shetty, who's associate professor in intervention radiology and in Tata Memorial Hospital, Mumbai. I think I'll invite Dr. Vasudev. You can start your session.
Hi, I think, am I audible?
Yes.
I'll just share my screen. Is it visible?
Yes, it's visible.
Okay, sure. So, good evening, everyone, and thank you so much for inviting me for this talk on oncological emergencies. And I will be dealing more on the medical aspects, and the surgical aspects and the intervention aspects will be covered by the speakers later. So I think everybody will agree that everybody is kind of running with some or the other time is a constraint for everybody, and time does matter when it comes to certain oncological emergencies like tumor lysis syndrome, hyperleukocytosis, mediastinal mass, superior vena cava obstruction, spinal cord compression, and febrile neutropenia. So in these emergencies, yes, time does matter, because if we do not pick them up on time and correct it or treat it, this will become irreversible. And that is why early recognition is very important. Because of time constraints, what I have done is I have made a few case scenarios, which are real life case scenarios, which we have encountered in our hospital over the past 3 to 4 years. And this will guide us through all the oncological emergencies which I have discussed. So scenario 1 is actually a 6-year-old girl who presented with a rapidly increasing swelling over the face and fever for 2 weeks duration. So this is how she presented with proptosis as well. And on evaluation, what we found is that hemoglobin was low, platelets were low. There were occasional atypical forms which were seen in the peripheral smear. Along with that, biochemistry revealed a very high LDH, almost 2300 on dilution, and the uric acid was elevated. So we just did a bone marrow to confirm the diagnosis, which showed L3 blasts, and flow cytometry had confirmed Burkitt's lymphoma. When we did a staging, we found that there was disease in the orbits, there was intracranial extension, there was disease almost everywhere in the body. There was ascites, there was marrow involvement. We also did a CSF analysis, which was positive for malignant cells. And the final diagnosis that we got, just a minute, was a stage 4 Burkitt's lymphoma with marrow and CNS involvement. So this is actually an ideal setting for tumor lysis syndrome. And what is tumor lysis syndrome is basically there is a cell death which is occurring in a rapidly proliferating tumor. Along with the therapy that is given, it leads to cell death. So whenever there is a cell death, there is a release of the materials which are there within the cell, which is potassium, phosphates, and nucleic acids, which causes the problem. So hyperkalemia, hyperphosphatemia, secondary hypocalcemia, hyperuricemia can all lead to renal damage, cardiac effects, eventually leading to multi-organ dysfunction. So this girl, coming back to this child with the high uric acid, we had given her rasburicase, which I will inform later what it is about, and also initiated therapy. So within the first dose of a steroid, she started developing tumor lysis syndrome, and her potassium was 7.2, phosphorus had shot up to 14.8. Uric acid had come down, that is because of rasburicase, and there was secondary hypocalcemia. So what we mean by TLS, we can define it as laboratory TLS or clinical TLS. This is called the modified Cairo-Bishop score. So lab TLS is abnormalities in 2 or more of the following, which occurs within 3 days before or 7 days after initiation of chemotherapy. And easy way to remember is increase in uric acid, potassium, phosphorus by 25% and a reduction in calcium by 25%. Clinical TLS is basically lab TLS along with creatinine, which is more than 1.5 times, arrhythmias, and presence of seizure. So how do we prevent it, and what are the strategies that are used? Basically, hydration is the most important step, and wherever you read, you will get that 3 liter per meter square is the fluid that you need to give. But more important to know is whether there is a need to alkalinize. There are many centers still practicing giving soda bicarb tablets, soda mint tablets, giving soda bicarb along with the normal saline. But there is actually no need to alkalinize urine. When the pH goes below 5.5, there is an increased risk of developing uric acids. And when the pH increases beyond a certain level, after 6 or higher, there is a capacity to develop calcium phosphate crystals. So basically, just giving hyperhydration itself helps with normal saline, and there is no need to add the alkalinization, because uric acid we can always deal with by giving rasburicase, but if the calcium phosphate develops, it is difficult to treat. But 3 liter per meter square is not for all patients. We need to be very careful. We have certain times patients who present with severe anemia in failure, where if we give 3 liter per meter square, it can actually precipitate congestive cardiac failure. In cases where there is a mediastinal mass, again, we would avoid giving very high fluids. We would start the therapy, give probably maintenance, see the urine output, and then gradually increase. In patients who are anuric, again, we need to be careful because they have a higher risk of developing pulmonary edema. Intake output needs to be monitored strictly while giving such hyperhydration. And this is the most important step for TLS prevention and for treatment. So this is the normal scene that we have in our wards, where such patients will have stacks of normal saline along with the bag to measure the urine. So I will not go into details of management of each of the complications, which will take a lot of time, but most important to highlight is that if there is hyperkalemia, again, aggressive hydration is most important. Although many books mention that calcium gluconate is one of the first steps to be given when there is hyperkalemia, we should remember that whenever we give calcium gluconate, it could precipitate with the phosphorus and lead to formation of calcium phosphates. Similarly, other steps that can be used is using cation exchange resins, which will take about 24 to 48 hours. Stopping giving the potassium supplements, so avoiding tender coconut, fruit juices, again, is very important. And with depending upon the level of potassium, one may decide upon using dextrose insulin infusion, loop diuretics, and sodium bicarbonate. Hyperphosphatemia, on the other hand, again, aggressive hydration is what works, but there are commercially available agents like aluminum hydroxide, sevelamer. Aluminum hydroxide is present in syrups like Gelusil. And hypocalcemia is again mainly by management of hyperphosphatemia. Hyperuricemia, again, managed best by aggressive hydration, present by giving allopurinol or febuxostat, which is approved in children more than 12 years of age. So this will prevent the formation of uric acid. But if there is already uric acid which is already formed and deposited, urate oxidase like rasburicase will help. And hemodialysis if there is a anuria with acute renal failure. So this is briefly about how TLS can occur, but the subsequent cases will also give more highlights into other problems, oncological emergencies. So the scenario 2 is a 13-year-old girl who presented to the emergency with fever and weakness, generalized weakness for a duration of 7 days. She was pale and had massive hepatosplenomegaly. and her complete blood count had shown elevated WBC count 3,27,000 with 94% blast. She had anemia, severe anemia, and hemoglobin was 4.6, platelets were 16,000. A peripheral blood flow cytometry done, it was suggestive of a AML. So basically the problem here is hyperleukocytosis. So what I will be dealing with is what is hyperleukocytosis, which conditions actually have a higher risk of hyperleukocytosis, what is the basic pathophysiology, what are the symptom signs, and what is the treatment. So hyperleukocytosis is basically initial WBC count in the peripheral blood more than a lakh and clinically significant. That means the symptoms occur then CML in cases of CML or ALL when the counts increase more than 3 lakhs, or in cases of AML where the count is more than 2 lakhs. Threshold is generally lower for AML because these blasts are large. There are actually 2 times more larger and more stickier. And it is seen in almost 10% of the ALL, 15 to 20% of acute myeloid leukemia, and almost all CMLs. Again, frequency is more with AML compared to ALL. Again, AML, M4, M4, M5 types have a higher risk of hyperleukocytosis. T cell more compared with B cell, but whenever it occurs in B cell, it is usually associated with PH or a MLL gene rearrangement. And infants have a higher risk of developing hyperleukocytosis. So two theories for causing the problem, that is rheological theory and endothelial interaction. Rheological theory is where these blasts, which are less deformable, go and cause occlusion of the blood capillaries, and this will lead to the leukostasis. Endothelial interaction is where these blasts will, the endothelial cells activated by these blasts will release cytokines, which will lead to symptoms. So what are the signs symptoms? Basically, what organ is involved that can cause the problem. So if CNS is involved, it could lead to confusion, drowsiness, headache, stupor, coma, blurred vision. If it is the lung, it is dyspnea. If it is vascular, it could be anywhere, retinal, it could be kidneys, which will lead to renal infarcts, priapism, renal vein thrombosis, thrombocytopenia, DIC, and eventually renal impairment secondary to TLS. So how do we manage hyperleukocytosis? It is basically the scenario one, which is prevention of TLS, where we use hyperhydration, um, uh, looking at uric acid, maybe giving rasburicase, biochemical monitoring. So this biochemical monitoring depends from case to case. Sometimes when you have very high levels of potassium, you may require monitoring every 4 to 6 hourly as well. But this is again based on the risk of developing tumor lysis syndrome. Along with prevention of TLS, the most important step is reducing the leukocyte count. And this is done by first getting the diagnosis early. So here in our case, we did a peripheral blood flow, which was suggestive of AML. And in cases like CML, hydroxyurea can be started. Leukapheresis can be used as in few scenarios, but it is contraindicated whenever there is DIC, APML, etc. Exchange transfusion is basically where we remove a certain amount of blood and exchange it with plasma and whole blood. Platelet transfusion again is given in these scenarios because they have a higher risk of bleeding, and generally the platelet threshold is kept at about 25 to 30,000. And I've written here avoid PRBC, but again that is because if you give PRBC whenever there is hypoleukocytosis, it can lead to hyperviscosity and more symptoms can develop. That's why even if you have to give a packed red cells, then maybe giving a small aliquot of 5 ml per kg and then slowly building up the hemoglobin is a better option. So we have seen now two scenarios. One is the tumor lysis syndrome and the second one is hyperleukocytosis. The scenario third is this boy, 17-year-old boy who presented with difficulty in breathing for 3 days and had a history of fever for about 7 days. In the X-ray, we can see there is mediastinal widening, so there is mediastinal mass. When we did the evaluation, again, the hemoglobin was low, platelets were low, WBC count was high, 4,30,000 with 95% blast. And tumor lysis syndrome parameters showed elevated uric acid, high LDH. So here in these scenarios, not only we have the problem of tumor lysis syndrome, But we also have the issue of hyperleukocytosis, plus we have a mediastinal mass. So here the management again includes tumor lysis syndrome prevention using all the measures. Like I had mentioned before, hyperhydration 3 liter per meter square may not be the ideal strategy, but we start slow. So maybe start with maintenance and then gradually go up to 3 liter per meter square, depending upon the urine output. Positioning is again very important because the mass compresses on the superior vena cava. So it is preferred to put the patient in a left lateral position. IV line positioning, sometimes it is preferred that the IV lines are secured in the lower limbs, because here you have the superior vena cava which may be obstructed. So putting an IV line in the upper limb may not be a great idea. So that's why it is better to secure the IV line through the lower limb. So again, we have the hyperleukocytosis part here. So we need to establish the diagnosis early by sending maybe a peripheral blood flow cytometry or doing a marrow, but depending upon the scenario. Fluids I mentioned need to be careful. Again, diagnosing early is important, and initiating the chemotherapy early, preferably here steroids are what is preferred, dexa or prednisolone. And the next step being monitoring the tumor lysis syndrome parameters.
Dr. Vasu, sorry to disturb. 2 minutes left.
So quickly running through the next scenario, which is a paraplegic child, the 17-year-old boy who presented with weakness and urinary retention. So I will skip these slides, but important to remember that these lesions could be intradural or extradural. And intradural, it could be intramedullary or extramedullary. There are a lot of causes which can cause this, but the mechanism with which it leads to problem is important, that it causes vasogenic edema, which leads to compression of the arteries, vertebral arteries, which leads to hypoxia, release of these VEGF and other inflammatory mediators, which causes the neuronal disintegration. So again, reaching diagnosis early is very important. So CBC, peripheral blood smear examination, sometimes a lymphoma, leukemia could also be present with these symptoms. Serum alpha fetoprotein beta HCG sometimes may be elevated when there is a midline mass. Biopsying as early as possible. I think Dr. Nitin will cover it. And probably if there are certain markers on the complete blood count, marrow aspirate and biopsy will help. So management here will be spinal stability, adequate pain control, may require opioids, constipation, urinary retention needs to be addressed, and again tumor lysis syndrome has to be considered. So the definitive treatment again depends mainly upon the neurological status. The aim is to regain the lost neurological function here and to attain diagnosis at the earliest. And sometimes steroids is probably the best to start as soon as possible, but one has to be very sure that you are not masking a leukemia diagnosis, or sometimes steroids can cause regression of tumors, especially in lymphomas. Surgery can be considered if chemo or steroid is not effective in 24 to 48 hours, and laminoplasty, laminectomy, along with tissue diagnosis can be considered. Radiotherapy is another modality that can be used. And briefly about the most common scenario that we see, febrile neutropenia. I think the takeaway messages would be to initiate treatment with broad spectrum antibiotics within 1 hour of presentation. Whenever there is a increase in the time of giving the antibiotic, the mortality increases by about 7 to 8%. And this has been shown to consistently in adult as well as pediatric studies, where that if the delay is more than 60 minutes, when the delay is less than 60 minutes from the first shot of antibiotic, the need for ICU consultation or admission is significantly reduced. So to summarize quickly these 5 scenarios, oncological emergencies do not give much time. Early identification, appropriate measures will always be life-saving, because most of these conditions that we see in children have a very good outcomes. Important to initiate the chemotherapy at the earliest, but again, establishing diagnosis early is crucial. Febrile neutropenia, always remember there's a golden hour of antibiotic. The earlier you give, the better is the outcome. Probably because of lack of time, we will skip the questions and take during the panel discussion. Thank you so much.
Thank you so much, Dr. Vasu, for this concise talk and keeping it very easy for the audience by giving, case-based scenarios. So with that, I'd like to move ahead with the next talk, which is by Dr. Shalini Mishra, and she will be covering the surgical aspects of pediatric oncology emergencies. Over to you, Dr. Shalini.
Yeah, thank you. I just need half a minute to start screen sharing. And meanwhile, I think we've covered a few of the very important emergencies. A very good discussion as well. Very good presentation as well.
If anyone has any questions, please feel free to put it up in the chat box. We'll try to address it at the end of all the talks.
I think what I would request is that either Monica
Ma'am, you want us to share the slides?
Yeah.
Yeah, I'll just have your slides. Just 1 second, ma'am. You can please let me know, ma'am, when to change the slides. I hope the slide is visible.
Yes, sir, it's visible. Just, yes, sir.
Yeah. Shalini, ma'am.
Yeah.
Yeah.
So there's some connectivity problem, I think.
Ma'am, I've shared the screen. You can just let me know.
Yeah, I can see that now. Thanks. Yeah, thank you so much. So can you hear me?
Yes, ma'am.
Can you hear me?
Yes, ma'am.
Okay. So I'll be talking about some of the pediatric surgical oncological emergencies, and as we all know that sometimes there's a lot of critical decision making which is involved. Most important question is whether or not to operate, especially if it's a hematological malignancy and there is a surgical emergency in that child. So keeping a high index of suspicion is very important. And also we must be, as surgeons, we must be aware about all the details, even the hematological malignancies, which we don't see regularly, and what are the risks of doing a surgery and what is the best timing, and also the hematological status of the patient, mainly the counts. Next slide, please. So these emergencies, the surgical emergencies, they can either present when the child first comes to us at the time of primary diagnosis, or it can be, which is most often it's seen that it happens during the medical treatment. Sometimes there are some emergencies which we see perioperatively and rarely during follow-up as well. Next slide. So I'll be briefly touching on intestinal obstruction, neutropenic colitis, urinary tract obstruction, airway obstruction, and tumor rupture and bleed. Next slide. So I thought it would be a good way to represent this with a small case. This was a 9-year-old boy who was diagnosed as a Burkitt's lymphoma. If you can see, there is a mass, mesenteric mass on the upper left side of that first top imaging. And he received, it was group B stage 3, yes, that's right. And you can see the uptake on the PET also. And he received 2 cycles of copadum, and after that, about 8 days later, he presented with bilious vomiting. So if you see the third image, which is an X-ray abdomen, which we have done in the supine. So again, it's very in erect position. So it's very important to do both erect and supine X-rays if you're evaluating the abdomen. Obviously, his abdomen was soft, but he was having bilious vomiting. So you can see that the stomach is a little dilated with the air fluid level, and the rest of the abdomen is quite gasless. So we waited for a day or so, and then again we did a gastrographin because his Ryle's tube was just pouring out golden yellow bile. And so the gastrographin showed there was some dilatation of the stomach and duodenum, and the area, if you look at the 5th image, the bottom left one, you can see there's one area where the dye is not seen very clearly, and that is close to the DJ flexure where the mass was. But however, the delayed images, all the dye went down. So we continued the, conservative management, thinking it may open up. So what is happening? Next slide, please. What is happening is, as the tumor is shrinking with the chemotherapy, it causes fibrosis, and that sometimes can lead to bowel obstruction, and especially happens with a lot of Burkitt's lymphoma, especially with the ileocecal junction. So because he didn't settle another day or two, and then we did a contrast CT, and here it was much more clear that the stomach is hugely dilated, as you can see. And in the second image, you can see that the duodenum, the second part and third part of duodenum. And that's the stomach, and this is the third part of duodenum. That's also dilated. And after that, the rest of the bowel is collapsed. And you can see that the mass has nicely regressed. Yes, just above that, the pointer, you can see the mass is there. It has regressed, but it's sitting somewhere near the DJ flexure and also the aorta and the superior mesenteric artery. Same things are seen in the lower distinct. So definitely we had already waited for 3, 4, 5 days, so we had to go in and explore, and we found this stricture in the third, fourth part of duodenum, and we had to do a side to side duodenojejunectomy. We did not attempt resection of the mass because the vessels were all there, and we know that it's a very chemoresponsive disease. Next slide, please. And we just did a biopsy, and that showed no viable tumor. It was just like one. So some of the intraoperative pictures where you can see in the first image that the mass is there just to the left of the pointer, and the duodenum is quite dilated below that. Yes, yes. And then when you look at it from below, you can see the stricture near the pointer. And the third picture is showing us the anastomosis that we did. We did not attempt to resect that stricture because it's a very tricky area, the duodenojejunal flexure, and also the vascularity, and the mass was also sitting there. So we just bypassed the obstruction. Next slide, please. So this is one example where we had to go in. Many times it happens that, as it is, it's rare, but it happens that you're able to manage. Maybe it's adhesive obstruction, or sometimes some transient interception. Interception is another presentation, especially in younger children, where we have to be careful. And if the age is less than 2 years, usually they're just idiopathic. But as you see it more in older children, there may be an underlying cause. So it's very important as surgeons, when we operate interception in older children, we must send the specimen for histopath. Sometimes it's missed, and the mass grows back again very quickly, as in Burkitt's. So up to 48 hours, closely observing an intestinal obstruction is acceptable, as long as the child is stable and is not gone into shock. And we try to do the minimum surgery with the least delay in chemotherapy, because all these hematological malignancies, any delay in chemotherapy will finally affect the outcome. And often we'll end up doing ileostomy, colostomy, or a feeding jejunostomy just to tide over the duration of the chemotherapy. And after that, later on, we can do the reversal once the chemotherapy is over. Next slide, please. There's another child, 2.5 years old, and known case of, he was diagnosed as ALL and underwent 2 months of induction. After that, he just came with a abdominal pain. So any child who comes with abdominal pain, usually we definitely admit, even though this child was not very neutropenic, but the pain was significant, and so we admitted for observation, and always a surgical reference is done. And if there are any signs, or if it doesn't just look like gastritis, then we definitely do an X-ray abdomen. And here you can see both supine and erect are very important. The supine X-ray is definitely showing some dilated loops and bowel wall thickening as well. And the erect one has actually taken the diagnosis, and there's a perforation. We can see air under diaphragm very clearly under both the diaphragms. Next slide. So obviously this child had to undergo an exploratory laparotomy. It's not always that you get a enterocolitis, a neutropenic enterocolitis, and you have to operate all the time. I think in the last 8 years, I would have operated on about 4 patients. Because unless there's a perforation, or if the child is not settling down with the conservative management, then we have to go. For this child, there were multiple perforations, total of 9. And so we had to resect some part of the ileum and also close a few of the perforations separately. Luckily, he did well, and he was able to complete his treatment, and he's on follow-up and he's doing well. Next slide, please. So neutropenic enterocolitis, I think it's one of the most common intestinal complications which we see during treatment of children with cancer, especially leukemias. And more often it is around the ileocecal junction and causes this inflammation of the cecum and typhlitis. And it can be a life-threatening condition because of all the inflammatory, hemorrhagic, and necrotizing involvement. So an early diagnosis and also prompt treatment. Next slide, please. Keeping the child nil per oral and giving good adequate amount of IV fluids. All those things are equally important. Next slide. And also, another thing I do is I usually add Metrogyl to the antibiotics, because if there is any translocation of bacteria, of the gut bacteria, or any perforation or impending perforation, at least it will cover a little bit. Of course, most of them, if they're neutropenic, they'll be on broad spectrum IV antibiotics. Another important thing is, many of them may be on steroids, or they may be taking a lot of oral medications like allopurinol or rasburicase or whatever else is required for their treatment. And so we may have to change all of them and see what we can give IV or some pain medications. And very important to monitor vitals and serial abdominal X-ray, especially if the child is in BMT and is having necrotizing enterocolitis. We would rather do X-ray abdomen, maybe bedside also, and lateral decubitus, morning and evening, twice a day. And the surgeon should definitely examine the child twice a day as well. You may need to shift to ICU. Next slide. This is another scenario where a 3-month-old baby with a bladder prostate RMS, the biopsy was done, and the child was given the first dose of chemotherapy and tolerated well and was sent home. And after another 2 days, the child was admitted to ICU in the middle of the night with a huge abdominal distension, and somehow the intensivists, they could not figure out, because it was a very small child and the abdomen was huge and the child was looking very sick. And the X-ray was done. Actually, there is a large shadow in the pelvis, like, rounded shadow, which is the distended bladder. So because of the biopsy, there was some more edema. And as you can see, this was a 3-month-old child with a 7 centimeters bladder prostate RMS. So it's a huge, huge mass, and it was already causing partial obstruction of the urinary bladder, and the child had gone into urinary retention. So obviously, for the surgeon's role here, it was an emergency. The child was really sick, and because of that distension, because even the breathing had become shallow. For a small baby, that's all that it requires. And a huge bladder was all that was required to push the child to ICU. So recognition that yes, this is the bladder, and a catheterization, and immediately everything resolved. So next slide, please. So sometimes some small things, even though it's not surgical, but the surgeon has seen and we're able to diagnose this. Other causes of urinary obstruction other than a bladder prostate mass and RMS could be any large pelvic mass like an ovarian GCT or a presacral mass, which can again cause hydroureteral nephrosis. As you can see here, the left kidney is really blown up, and this child required a suprarenal percutaneous nephrostomy to tide over, and then we gave chemotherapy. So again, an infant, and then later on this tumor shrunk, and then we operated later. Next slide, please. The airway obstruction is also important. It can be a surgical emergency, although we don't always run inside and run to the OT and operate. But sometimes that's the only way, like a huge teratoma or a germ cell tumor in the neck, which is causing airway obstruction. Especially if it's a teratoma, it won't respond to chemotherapy, so we have to go in and remove it. The other tumors that can be there in the neck can be neuroblastoma or rhabdomyosarcoma or lymphoma as well. So whenever there is a neck mass, it's important to look for stridor and especially check the positioning. And it's already been discussed about your superior vena cava syndrome and other things. So, diagnosing urgently and starting treatment, which may be steroids, chemotherapy, is very, very important. And it's actually an acute emergency. And as the previous speaker said, the time is ticking and we may just lose the child if we don't act on time. Very rarely we need a tracheostomy. And remember that in case of mediastinal mass, we never do a tracheostomy because that is not going to help. The obstruction is, distal to where the tracheostomy tube can reach. Next slide, please. So this brings me to the most dreaded surgical emergency in pediatric oncology, and that is tumor rupture or bleed. So all our surgical management, which is quite different from the adult surgical oncologist, giving neoadjuvant chemotherapy for large tumors or maybe all tumors, and doing very careful surgery in a small child. It's all moving around. I have to avoid spill. I have to avoid tumor spill, and especially with Wilms tumor. So the rupture could be either because of trauma or it could just be spontaneous. And of course, large tumors are more prone and they may need urgent life-saving surgery. But nowadays we have intervention radiologists who can come to our rescue, because even the surgery is not going to be easy. You will need a lot of blood products, and you will need quick decision and good anesthesia and post-operative care. As large tumor, also it's also bleeding. And you have to first identify where the bleeding is. Where it has a or pre-operative elaborate more on that. Next slide. Slide. Encourage all the young pediatric surgeons to emphasize how to avoid tumor spill in a Wilms tumor, because that will upstage it to stage 3. And using the PSYOP approach, especially in our country like ours, is definitely much better. And a large incision, don't try to go for a small incision. A good medical surgery, never do it in a hurry. And you need a good assistant and very gentle handling of the tumor, especially when we're giving traction. I always make sure that I'm the one who is giving traction to the tumor, so that if there is a spill, I take it on myself and I can't blame my assistant or anybody else. Especially if you have a cystic or necrotic tumor, you have to be extra careful. Next slide, please. And again, you need to know in case there is a spill, now what to do. You can do packing, you can do a thorough wash with distilled water if you have, or 10% povidone iodine. And of course, you have to upgrade the chemotherapy and give radiation within the first 14 days. And nowadays, a spill is a spill. So there's nothing like localized or generalized spill, especially for Wilms tumor. This is what I'm talking about, Wilms tumor. So in case there is a spill, we have to give whole abdomen RT. Next slide. I think that's about it. Thank you so much for your kind attention and for this opportunity. And again, I apologize for the delay in starting this presentation. Thank you.
Thank you so much, ma'am, for this comprehensive talk and, highlighting the fact that despite these are very sick babies and emergencies, if we rectify or we pick up in time, we can even manage some cases conservatively. With that, I would like to call upon the third speaker, which is Dr. Nitin Shetty, to highlight the importance of intervention radiology in these cases. Over to you, Dr. Nitin.
Hi, thank you, Juhi. It's nice to see some familiar faces. Hi,
Yeah.
Monica, thank you for the opportunity. And Vasudev, it was a fantastic talk. So was by Dr. Shalini. I think pretty much she has covered the most important part of IR, where she specifically mentioned that when it comes for emergency bleeding, IR would be the first on call to control the bleed. So, Vasudev, if you can just give the control for me, I can share my screen from this end.
Stop share.
Yes.
Yeah. Just a second. Yeah, is my screen visible?
Yes.
Yeah, all right. So I'll start with the first case. So a 5-year-old boy presented with abdominal mass. He was diagnosed as abdominal Burkitt lymphoma, which was biopsy proven, and was staged and risk group as stage 3, group B. And his baseline LDH was 850 international units per ml, which was more than twice the upper limit for the lab range. The rest of the biochemical parameters and the hemogram was normal. So my question to Dr. Vasu would be, what will be your initial management in this case, and what all things will you keep in mind while treating and monitoring this child? I mean, what will you monitor?
So this is a stage 3 group B Burkitt's lymphoma, and LDH is slightly on the higher side. So we know that this particular child is at a higher risk of tumor lysis syndrome. So what we would do is we would start this child on a prephase COP, that is using cyclophosphamide, vincristine, and prednisolone, and monitor the tumor lysis syndrome parameters. So the frequency of TLS monitoring may depend upon what the reports come in as. So you may require something like 8 to 12 hourly monitoring. And along with that, we have to start all the anti-TLS measures that are required, like for uric acid, for after looking at the phosphorus, then maybe adding aluminum hydroxide, 7-ml, hydration, monitoring the intake output, as we discussed in the first case that I presented.
Yes. So as you said, Dr. Vasu, we started this child on prephase COP chemotherapy comprising of steroids, BCR, that is vincristine and cyclophosphamide. And on day 5 of his prephase, he complained of abdominal pain, vomiting, and constipation. On examination, there was tachycardia. Rest of his vitals were stable. And on clinical examination of the abdomen, there was guarding. No bowel sounds were heard. And this was the X-ray, which was done after examining the child, and which showed that there was free gas under the diaphragm. So my question to Dr. Shalini would be, what is your working diagnosis and how will you manage this complication?
So definitely there is a bowel perforation, and I would think that either it's the mass which has kind of eroded into the bowel, or the inflammatory response, or there is a neutropenic enterocolitis. So this child definitely looking at a large amount of air, and you said the child is tachycardic. So we probably need to go in and operate on this child.
So this child did undergo urgent exploratory laparotomy, and the finding was that there was a jejunal perforation, which can be seen in the image, measuring 2.5 by 1 centimeter, and was surrounded by necrotic bowel. And also there was gross contamination of the peritoneal cavity, and resection and jejunostomy was done, along with long Hartmann pouch were created. So, Dr. Vasudev, my question to you would be, is it advisable to take up such a child who is received chemotherapy on day 5 of chemo, is likely to be immunocompromised for such a surgery? And what is the rationale behind using prephase COP before directly starting with intensive chemotherapy?
So to answer the first question, is it advisable? Yes, it is required because it is an emergency and we need to go in. And generally one feels that by giving prephase COP, the tumor lysis syndrome risk is reduced. But that is not the case. Actually, the prephase COP is designed in such a way that you don't want to make the patient more, myelosuppressed. Because especially when it comes to abdominal Burkitt's, one has to remember that there is a risk of perforation, especially in the initial few days of therapy. That is when the tumor actually starts to melt. And one may end up in a scenario where we have to do a surgical procedure. So the benefit of giving a pre-phase COP compared to using, directly going to LMB or MCP 842, any protocol that is given, is that you will not get neutropenia along with the pre-phase COP. And the child is not neutropenic in case if surgery is required. So in that scenario, that is the perfect thing to do. I mean, this is an ideal scenario where this patient will recover quickly after surgery as well, and one may need to give another COP just to bridge the time and then start the main therapy.
All right. Thank you so much. So this child completed his chemotherapy. Jejunostomy takedown was done after the completion of the entire chemotherapy. The adhesiolysis was also needed for dense adhesions, and currently the child remains disease-free and asymptomatic 17 months post-diagnosis. Dr. Monica, is Dr. Nitin ready, or should I go ahead with the second case? Because this. Yeah, so my second case is a 3-year-old male. He presented with pain in abdomen and intermittent hematuria since 2 months, and a lump felt in the left lumbar region since 8 days. There was history of fever and vomiting since 5 days. On examination, the child looked sick. He was sick looking. There was a temperature of 101.5. Heart rate was 130. There was tachycardia. Respiratory rate was 28. There was some tachypnea, and saturations were normal. The BP was 110/70, which was more than the 95th percentile. So the child was hypertensive. There was no dysmorphism. Genitalia were normal. And on per-abdominal examination, there was distension with fullness on the left side, diffuse tenderness and guarding present. There was a palpable lump in the left lumbar region, 12/12 centimeters, which was tender, firm, non-palatable. No organomegaly, and other systems were normal. In this case, Dr. Vasu, what would be your working diagnosis, and what initial tests would you recommend in this case?
Yeah, so this is a sick child presenting with abdominal mass, hematuria, and there is a mass which is palpable. So probably a renal origin itself. And so I think we will have to evaluate, probably looking at what is the epicenter from where this is arising. So probably an ultrasound first will kind of give us an idea. But looking at the child being so sick, thoughts that it could be a rupture or could be a intratumoral bleed could be a possibility. So I think complete blood count, getting an ultrasound, which will help to know what is the epicenter, whether there is any bleed within the tumor, and getting the basic liver and renal function tests will be the first step, along with getting cross match, coagulation parameters. All this will be the first things that we'll look at.
Yes. So as suggested, we did a laboratory workup. So the hemoglobin was 6.5 with a hematocrit of 18.9. There was normocytic pneumochromic anemia on the smear. The WBC count was 14,1100 and the platelet count of 130,000. The biochemistry was normal and the coagulation profile was normal. And we did an abdominal sonography, which revealed a large heterogeneous mass with internal cystic components in the left upper quadrant with origin in the left kidney. And there was a comment saying that the left renal pelvis and left retroperitoneum contained ecogenic fluid. So this was the CT abdo-pelvis, which was done with oral and IV contrast. Nitin sir, are you there to comment on the CT? Okay, Dr. Vasu, would you like to take up this question?
Yeah, even I think Shalini ma'am can just probably add. But looks like prima facie like a renal mass with some bleed which is there. So ma'am, maybe if you can.
So in these images, we can see the right kidney clearly, but the left kidney is not very well visualized. And there seems to be a, area without any uptake of contrast, and probably I'm thinking that's a hematoma, which is almost occupying the entire left renal fossa and the retroperitoneum as well. So there is a high index of suspicion that there is a tumor rupture and bleed here. So renal masses, usually they are a little, the rupture is contained because it's retroperitoneal. And suppose it was an intraperitoneal rupture, there is no second thought, we have to rush and go and operate, because then there is nothing to control the bleeding, and then the child can just exsanguinate. You know, the blood volume is only that much for a child, 70 ml per kg. When it's a retroperitoneal rupture, sometimes we can try and manage if the child is stable with very, very close monitoring, just like it would happen in a case of a road traffic accident with renal injury. Earlier, we used to operate much more often for even for liver and spleen injury, but now more and more we are going towards conservative. Also because we have, if we have a backup of interventional radiologist, we can, give a trial of conservative treatment.
Okay. So the CT, as we saw, had revealed a left kidney mass with subcapsular hematoma. There was retroperitoneal hemorrhage, and there was also in the renal mass, there was an area of which was isodense with the aorta, which was suggestive of contrast pooling, which was consistent with the pseudo aneurysm. So as ma'am already said, how she would approach this case, and ma'am, what are the criteria for upfront versus delayed surgery in such a patient of suspected renal mass with tumor rupture?
So again, if the child is unstable and you're even despite some transfusion, you're not able to maintain the hemoglobin, that would be one definite indication to go in and operate. But as you're saying that the CT was showing some pseudoaneurysm, so even the surgery is not going to be easy. You have to be very ready, and you have a good anesthetist, and also post-op care should be informed. The ICU, if you're doing it in the middle of the night, somebody senior should be there in the ICU as well. Post-op ventilation, blood products, everything should be ready. And always, whenever there is this kind of an emergency situation, already the principles of oncosurgery, that is, you want a good clean resection, that is already violated, and it's likely to be more violated when we open up the abdomen. So it is a risky thing, and an experienced surgeon should be taking this up. And suppose it is, like I said earlier, the kidney has an advantage that it's contained within the Gerota's fascia. I once had a child who was hit by a sibling and had a small, got an ultrasound done and incidentally found to have a small Wilms tumor with a subcapsular hemorrhage. Now that bleed was controlled, it was contained. So we could have waited on that patient. But in this kind of scenario, I think it's very difficult to wait, but yes, whether we can make the surgery more safe by intervention radiologist going ahead and doing embolization of the renal artery, and then thus decreasing the chances of torrential hemorrhage during the surgery, that would definitely be a better choice. Yes, you've got a flow chart.
Yeah. So as ma'am said that if there are vital stable signs, and if all the parameters she discussed, if it's a localized rupture, there is capacity to operate, there is no tumor thrombus, it's not crossing the midline, we would go with immediate surgery. Otherwise, we would delay surgery and also take help from the intervention radiologist. So for this child, the child was given a PRBC transfusion since his hemoglobin was low, and he was referred to an intervention radiologist, and a selective left renal angiogram was done. So the angiogram showed that there was no active bleeding, but there was significant tumor vasculature in the lower pole of the kidney, which as you can see with abnormal dilated and tortuous vessels with areas of contrast pooling suggesting the pseudoaneurysm. And once the embolization of the left renal artery was done, the vasculature cleared. Nitin sir, are you there to take the question?
I'm there to try to show my presentation.
So are you ready? Then maybe we can, you can go ahead with.
I think I can answer the question along with the presentation if possible. If not,
sure.
you can just share the, give me the right to share.
Yeah.
Thank you. So this one last try. And okay. So okay, are you able to see the screen now?
No, sir.
Disappointing.
Yeah.
Okay.
We can see, sir.
Oh.
Oh, and it went away.
Okay. Let me see. Now?
Yes, yes. Can you click on the
Fantastic.
first? Yeah.
Great.
Yes.
No, wherever it starts, I will go on. Don't worry. I don't want to lose the screen again. Okay. Anyway, Kalpesh, thank you so much. I'll just disconnect. Okay. Kalpesh, thank you. All right. So let me quickly. How much time do I have, Monica?
So you can take 10 to 15 minutes. I'm sure it will be worth.
I'm sure that the dinner would be on table for the most of those people who are participating here.
So this is worth the wait.
Yeah. So scope of IR, this is pretty much simplified. It's all of you know, I don't have to go into that it is a minimally invasive treatment. And just like the two speakers, they were at the extreme end. One is conservative management and the other one is surgical exploration. We come somewhere in between. And definitely all the three, whether it is medical, minimally invasive IR treatment or surgical treatment, it forms the continuum of care. So depending upon when the child has presented, maybe the non-intervention would be best at times. Sometimes straight away surgery would be the best choice. At times, perhaps minimally invasive treatment would also be an option. So to put it in simple terms, either the scope of IR is to drain something that is unwanted, be it abscess or fluid or collection, to divert sometimes when there is leak. For example, biliary leak or urinary leak, you do not want it to go in the normal way and you want that to be diverted outside. So that is where we have a role. To close the bleeding vessel, that is whichever is leaking, we close, whichever is occluded, we open. So sometimes in case of the venous thrombosis or arterial thrombosis, this is what is required to open it up. And when it is the bleeding tumor, we would want to close the vessel. Of course, the most of the time we are called for access either by through PICC line or Mahurkar or the central line access under ultrasound guidance. This is, but I would not get into that. And finally, at times when there is definitely no way of feeding the child, or for either for feeding purpose or decompression purpose, we would want to have an access to gut, or there is enteric access also can be given by image guidance. Pretty much head to toe, we can do the intervention except for the the tumor of the brain, which we have not treated, started treatment as such, but definitely any other sort of emergencies like the embolectomy or stroke management or aneurysm coiling in case of mycotic aneurysms, anywhere, be it even including the brain, we are able to do it. The indications for the onco and non-onco cases are pretty much, or the procedures are same, but the indication would definitely be different between the onco and non-onco. And most of the time, onco patients, like the previous two speakers mentioned, they would present in case of mostly in emergencies. So one of the main dictum for us is there's a small child. Again, like you would have heard it multiple times, small child is not, children are not small adults. So, of course, it also includes the exposing them as minimally as possible for radiation. So that is one of the modality we use apart from ultrasound, which is non-radiation. The CT scan or fluoroscopy that we use has got radiation, and we have to use that as minimum as possible. So coming to the scope, either pleural effusion or empyema or pericardial or liver abscess, as you can see here, it can be drained by ultrasound. At times for difficult location to avoid the major vessels and bowel, you can see here the collection needs to be drained under CT scan. Again, as minimum radiation as possible, we have to use while doing these cases. Moving on to system wise in GI, like I mentioned, one of the indication is to have an enteric access. That is at times just passing a right tube blindly would not serve the purpose. We would want to do the placement under the fluoroscopy guidance. And second indication, like I mentioned, is to control tumor. So this is a case of 8-year-old child with a lymphoma. You can see there is a gastric outlet obstruction, stomach is dilated. And under fluoroscopy guidance, we are able to get across the gastric outlet obstruction and place this in the duodenojejunal junction. So where the child could be given nutrition. Another case for abdominal sarcoma of the nasal cavity, again, child present with cachexia. And in this case, a simple under fluoroscopy guidance, we distended the stomach and placed a large bore catheter, which is called a feeding gastrostomy tube. And the child was being fed through this one for while the child underwent chemotherapy for his primary ERMS. This we have not done yet, but in case of large bowel obstruction, if the bowel needs to be decompressed before any surgical intervention, again a simple procedure like I mentioned previously, just like how we do a gastrostomy tube placement, we can place similarly tube in the cecum or the large bowel to decompress that, so that give some some time for the child to become stable and also become surgically eligible for surgery. Common indication, again, it's the GI bleed. I have listed various causes, and what I'm going to deal with is those related to neoplasm. Again, it could be tumor per se that is bleeding, or it could be because of a complication of chemotherapy. Most of the time, it could be gastritis or enteritis or enterocolitis, which would cause a small ulcer, and it would continue to bleed if there is any bleeding parameters that are abnormal. So a case of 12-year-old lymphoma had started on chemotherapy, had upper GI and lower GI bleed. Patient was stable, underwent a CT scan. There was a suspicion pseudoaneurysm in the GDA. Child was taken for DSA. You can see here the celiac axis, the gastroduodenal artery. There is a small blowout which can be very easily tackled by placing a small coil. So again, like Dr. Shalini was mentioning, these are the cases wherein the major surgical intervention is not required. A simple angioembolization is possible. So another case, 8-year-old Burkitt's lymphoma presented with GI bleed. CT angiogram shows that there is an active bleeding. So this is the bowel. Inside the bowel, you can see a bleeder. We could identify that this is a second branch of jejunum. When angiogram was done, we identified where the second jejunal branch was. And then this angiogram shows that there is extravasation. So this is the point of extravasation. And subsequently, after angioembolization, you can see that the bleed is no more seen. So again, minimally invasive treatment. Another type of GI intervention coming to hepatobiliary, again, drainage of purulent collections if it's there in the liver abscess, or a biliary decompression. Again, this is required sometimes when the jaundice is too high and the chemotherapy cannot be started. Then a surgical and a percutaneous decompression can be very easily performed. Brought the bilirubin down for the chemotherapy to be started. Also, another indication is if the patient is in cholangitis. Please remember that it's a small child. Not all the facility would be available for doing pediatric endoscopy. So most of the time, even a percutaneous drainage would be more than sufficient for these children to initiate any sort of treatment. And the third treatment, of course, is the bleeding from any GI tumors. So emergency decompression, like I mentioned, it is either done in case of obstructive jaundice with or without cholangitis. So under sonography guidance, we puncture the bile duct, and then we do a fluoroscopy, inject some contrast to confirm that we are in a bile duct. And once we are sure, then we go ahead and put a pigtail so that the bile is drained outside. And if it is going to be there inside for a longer time, then we do the next step, what is called as internalization. From the CBD, we go down into the duodenum so that the bile can drain into the duodenum from the liver. So this is a case of internalization. So we have done a PTBD, gone across into the duodenum and have placed this catheter in the D3 so that the bile can go down. This is just an example to show that this is a large, the same case, but it's a neuroblastoma which was causing obstruction of the CBD. And now you can see that this CBD is in situ. Another example, extreme example, here this is a case of where the child underwent post Whipple's, and post Whipple's had a HJ leak. And again, it was too much inflamed, burst abdomen, not fit for surgery. So we was referred for a diversion PTBD. We did a diversion PTBD, can see that there's a massive leak. We are lucky to get the wire across into the jejunum, and subsequently we placed what is called as the covered stent so that the bile can drain directly from the liver into the jejunum. Coming to GI bleed, a large tumor. Here it was diagnosed as hepatoblastoma, which presented with bleed and was taken for emergency angioembolization. You can see the large tumor with blush, and post angioembolization there is significant reduction of the blush. So the patient becomes vitally stable, then he can be started on chemotherapy, and depending upon response, it can undergo surgical resection at a later date. Moving on to the GI intervention, again, drainage of collections, diversion of urine, control of bleeding from the tumor. And in this case, I don't have example at this point of time, but whenever post-surgery, if there is a occlusion of the artery or thrombosis of the vein, we can again re-establish the flow by doing mechanical thrombectomy. When do we do urinary diversion? As in this case, when there is dilatation, this is a case of urinary bladder RMS. You can see the growth in the bladder outlet obstruction, dilated pelvic ileal system. Under ultrasound guidance, puncture that, confirm that you are there in the ureter, and then in the PCS, and then you can place a pigtail. So here another example where 2 pigtails were placed for a child who presented with anuria because of obstructive uropathy. Again, apart at the other end where there is no obstruction but you need urine to be diverted, a case of urinary bladder RMS, underwent excision and ureterosigmoidostomy, developed urine leak. So on CT scan you can see that here from the anterior part of rectum it is leaking into the peritoneal cavity. A PCN, bilateral PCN was done. We could see the leak over here, and a simple diversion of PCN got the child out of this very stormy post-operative course, and went home without any major complication. Tumor bleed similar to hepatoblastoma. This is a Wilms tumor. I think something in this line was being discussed when I had logged in. Again, in this case, first reference was given for IR. We did an angiogram. You can see this is a normal kidney. This is a large enlarged tumor which is showing blush. It is so enlarged, and the patient has lost so much blood that all the vessels are actually quite are in vasoconstriction because of NORAD support. Post angioembolization, you can see that there is significant reduction in blood. Patient again became stable to undergo subsequent chemotherapy. Moving on to the bronchopulmonary intervention, most of the intervention that we do in pediatric setting for in the thoracic area is for control of hemoptysis. Again, it can be because most of the time it is because of infection rather than because of the tumor. As in this case, you can see that it's a case of ALL post therapy developed hemoptysis. You can see there is consolidation of the right middle lobe, and angiogram can shows multiple enlarged vessel by many arteries, which we have to get into each of them and successfully embolize so that the bleeding can be controlled. Extreme example, this is a mycotic aneurysm. You can see the consolidation over here, which is causing aneurysm of the aorta. Again, child who was started on chemotherapy, developing mycotic aneurysm. Child was completely unstable, not fit for any surgical management. So we did a percutaneous placement of stent graft. Here you can see this is the blowout, and we placed a stent across. And post stenting, you can see that there is no pseudoaneurysm seen. This happened recently, a 17-year-old girl. I'm still including that in the pediatric because it was operated by a pediatric surgeon. Neuroblastoma. This is a massive tumor here in the posterior mediastinum. Post NACT, it reduced significantly, and as the protocol, the child was taken up for debulking surgery. And during surgery, there was a small rent, and which just could not be controlled because there was tumor all around. And as a last resort, we just did a cut down of the iliac and inserted this stent graft under vision, and under fluoroscopy, we identified exactly where the aortic rent was and deployed the stent graft across that rent. So again, after a year, the child has come back. The graft is sealed the aneurysm quite well. There is no rent, no extravasation, and the tumor is pretty much stable. So pretty much last the area head and neck that I'm going to cover. Most of the time, JN embolization is the reference that we get for, and we do a preoperative angioembolization to minimize the blood loss at the time of surgery. At times, whenever there has been supply from the ICA, we have not embolized that territory for the risk of having embolization of the brain parenchyma also. So ICA territory is normally tackled by the surgeons. In this case, the child during introp continued to bleed, bled massively, could not be shifted down. So intraoperatively, we placed the needle into the tumor, and under fluoroscopy guidance, we injected blue so that the bleeding stopped and the surgeon could continue with the surgery. Another case, again, pre-op angioembolization done for a JNK. A child underwent surgery, uneventful 2.1 liter blood loss, but suddenly on post-op day 5, presented with massive bleeding from the mouth and nose. And despite resuscitation, the vasopressors and giving vasopressors, the BP was 40/20. Shifted to our cath lab. We have both CT and CM on the same table. So the CT scan showed massive bleed into the operated cavity. Did an angiogram. You can see that there is a big rent, almost to 50% of the blood coming out into the nasal cavity. Went inside, and within 10 minutes, we could do this coiling of the rent. And subsequently, you can see that the angiogram done from the contralateral ICA and the vertebral artery shows that there is good cross flow, and bilateral ICA was being on the right side ICA was being filled. A week later, the child was discharged in stable condition. So last couple of examples that I would want to give, this does not fall into any one particular area. So a case of Burkitt's lymphoma presented with GI bleed, but when we did a CT scan for evaluation, also found that the child had common iliac thrombosis. So there is bleed on one end and thrombosis on the other end. So because the child could not be started on any anticoagulants, we placed a filter in the IVC to prevent any life-threatening thromboembolism. So this is one of the indication for filter placement. And this is one particular procedure which gives us immense relief and satisfaction, despite not that the others don't, but this is one very simple procedure. At the most of the time, at the end of chemotherapy, when the child is good to go home, it does happen that the PICC line gets broken or the port gets displaced, and it goes into the pulmonary circulation or get lost in the heart. So this is one child where it was removed outside, and the physician over there told the only option remaining for the child is to go for a surgery where the heart will be opened up and the broken PICC will be removed. So luckily, there is someone mentioned that it can be done by IR route without opening the heart. And it is actually quite simple. Just go inside. We have got something called the snare, catch the broken PICC line and just pull it down. So it's just 10-15 minutes procedure, and it does not require any opening. So this is the beauty of minimally invasive treatment. So I have pretty much covered most of the pediatric emergencies. Beyond this, there are a lot of many IR guided therapies that can be offered for pediatric children, which is beyond the scope of today's talk. So sum up, we drain, we divert, we close the bleeding vessel, we open the occluded vessel. We can give access to the stomach, to the entry, to the gut. We can give access into the arterial system, venous system, or even the lymphatic system. Of course, lymphatic is not much of an emergency, but it does come in the scope of IR. So thank you very much, Monica and Juhi, for the opportunity. And it was nice to see you all again. If there are any questions, I can just take a couple of them.
Thank you so much, sir. It's definitely worth the wait. Any questions? I think one question has been already answered in the chat box.
So just one question, madam. If you have
I have a question to Dr. Nitin. So, in case of a suspected, yes, Monica, you go ahead first.
I wanted to ask you, if a patient
ask my question?
prostate RMS with obstruction, so should we catheterize or should we do SPC? If the patient presents with bladder prostate RMS in retention.
You're saying bladder neck obstruction?
Yeah, bladder neck obstruction.
Is it for me or for Dr. Shalini?
Dr. Shalini, just for the audience also to understand, should we put in a catheter or should we go in with SPC?
Usually, if it's possible to catheterize, I would prefer just doing a catheterization rather than putting an SPC. Very rarely have we done SPC for neonates with post-urethral valves we used to do, but for bladder prostate RMS, very rarely. Most of the times you're able to catheterize and then manage. But in case you're not able to negotiate a catheter and then rather than injuring the urethra further, you can, that's always there as an option. So and the other good thing is that they respond beautifully to chemo. So even if you have to put an SPC, after maybe two chemos or so, you will be able to remove it.
Okay. So actually it is question.
I had a question for Dr.
Yeah, Dr.
Yes,
Nitin,
yes.
right. Yes, ma'am, go ahead, please.
I had a question to Dr. Nitin.
For me?
In case of suspected rupture of tumor, like Wilms tumor, the one that you showed and the one that Juhi showed, is it, if it is quite clinically, we are really suspecting that this tumor may be ruptured and maybe bleeding inside, is it not better to go ahead with a CT, with CT angio rather than doing an ultrasound? Because, you know, in ultrasound, we give a lot of compression and pressure. And so I always have a little fear that while doing the ultrasound, we may be actually, promoting the bleeding, even if some clots are formed that it may get dislodged. For example, if it's a renal tumor, renal injury because of trauma, one of the instructions we say is nobody should palpate the abdomen again and again. Because again, we think that, we may dislodge that clot and the bleeding may start again. So what do you think about that?
You have answered the question, madam. So even if you have to do any intervention, the first thing that we ask for is a CT angio. Like there is no point in a child going on searching where the feeder, which artery is likely to be bleeding. So most of the time, if it's arising from the organs, say for example, Wilms, we know that it is renal. So if it's hepatoblastoma, we know that it is from the hepatic arteries. But at times, say post chemo, if it is colitis or enterocolitis, we actually don't know from where the child would be bleeding. So CT angio is our protocol, again for the same reason. That is an additional thing, that you would not be pressing the abdomen more to identify what's going wrong. Also, it's very difficult to do an ultrasound in a child who has got abdominal distension and in discomfort, crying. It is practically not possible to do. The simple thing is just get a CT angio done. Most of the time, our pediatricians or the anesthetists are good enough to just give the sedation for a CT angio to be done, and after that we take a call.
All right, Dr. Amit.
The time taken is also much less in the CT angio.
Hello, Dr. Amit. So this is question to Dr. Vasu. Dr. Vasu, what are the situation in which in TLS we need to go for dialysis?
So to answer your questions, I think anuria, like in a setting of a tumor lysis syndrome, currently probably secondary to uric acid, not much of a problem. But in spite that, if there is anuria which is persisting, you will need that dialysis. The second is hyperphosphatemia. Sometimes, even with the best measures with low urine output, again, one of the indications. Persistent hyperkalemia, which is not getting corrected with your medical interventions, again, you need to go for dialysis. And I think these will form the major ones, but I think the whole idea would be to kind of prevent it. But there are certain scenarios, like for example, we may have a patient with leukemic deposits in the kidney, or there may be a pre-underlying disease in the kidney. Creatinine may be already 3 or 4 when the patient is coming to you. So these are scenarios where you know that while you are going to start chemotherapy, it is going to get worse, and the kidney will not be able to handle more things. So here, what we do, which we have done for a couple of patients in KMC, is that in these scenarios where we had this child with TALL with bilateral bulky kidneys, and creatinine of 3 or 4 2-year-old child. We knew that if we are going to give DEXA, this is going to land up into a lot of problems. So we actually put in a dialysis catheter and we started the DEXA for this child. And subsequently, the first report itself had kind of uric acid had shot up, phosphorus had shot up, output was not great. So we kind of continued the chemotherapy or DEXA in this child, and she came out. I think she needed about 2 such courses. But yes, of course, all the settings may not have, like we have a pediatric nephrologist with us. So, and we discussed with him and we felt that is the best way out. So she came out, she needed about 2 sessions of dialysis, no tumor lysis. After that, everything settled and the kidney size also improved and urine output was really good after that. So I think individualized patients, but it depends upon the setting where you are in.
Yeah, thank you. Bye.
Yeah. So if no further questions, I think we can wrap up today's session.
Yes. Thank you, Dr. Juhi. Thank you, Dr. Nitin, Dr. Vasu, and Dr. Shalini ma'am for nice presentations. And Dr. Nitin, though it was late, but I think I definitely enjoyed your presentation. Thank you once again. Thank you, everyone.
I
Thank
would
you.
like to take a minute of all of yours. Can you just stop the screen sharing once?
For me,
Yes, sir. Can you?
before I stop sharing, I would want there's one just small advice that I want to give you. If it's possible for you to guide the presenter half an hour before the talk as to whether, or just to verify that everything is in order, that would be very beneficial, especially in a 1 hour talk. If I'm spending 10-15 minutes to log in, then that does not make sense. So it is just an advice. Henceforth, the speakers, you can make a rehearsal half an hour before. Thank you.
Definitely, sir. We will do from the next session, sir. So, well, thank you for extending us the opportunity to host the session, and I hope you had a seamless experience. So I will just take 1 minute to show our platform ClearNet before concluding the session. Thank you, everyone, for giving us that time. So we can conclude the session, right?
Yeah.
Okay. Thank you. Good
Yes.
night to everyone.
Thank you. Thank you.
Thank you so much.
Thank you.
Thank you, everyone.
Yes, sir. Thank you.
Thank you,
Thank
ma'am.
you.